Okay, Dr. Magdy Ali, our participants are eager to engage and learn more about your project. And we have a question here. Can you elaborate how the SUV max and the hepatic steatosis index are related, and how this connection helps to understand the changes in the liver that affect 18F FDG uptake in the cancer patients?
Okay.
This is our first question.
If patients have hepatic steatosis, like more accumulation of fatty liver, cause is a condition of inflammations. Like steatosis is condition of inflammation within the liver, like second stage of non-alcoholic steatohepatitis. Many patients have hepatic steatosis have also non-alcoholic steatohepatitis. So these patients have inflamed condition within the liver. The effect of inflamed conditions is within the PET-CT increased uptake of SUV. So is inflamed area, okay, of the liver. You can now by FDG is radioisotopes go to a non-cell like cancer cell and also inflamed area. So the liver more uptake of FDG because it's inflamed. When more uptake FDG, you can get more SUV max value. So the liver is inflamed. Then it should be take the liver as a reference, because you can get the liver reference within the cancer patient. You can get uncertainty result when take a tumor background ratio in case cancer patients.
Okay, thank you very much. And we have the other question here. How does hepatic steatosis in cancer patient influence the metabolic activity of the liver? And what implications does this have for the accuracy of the 18F FDG uptake in the PET scan?
Okay. So many metabolic dysfunction like obesity, like poor diet, like many condition of metabolic syndrome come from non-alcoholic fatty liver disease, because the liver is a main factory of the human body. So it can cause is damage of sequence of damage of hepatocyte from nucleus, firstly nucleus to exit of free fatty acid and triglycerol, increase level of hepatocellular lipid within the liver, or increase hepatocellular lipid of the liver, increase sizes of the lipid, compared with the rate of oxidation by the liver, is digestive of lipid by gallbladder or bile fluids by gallbladder, increased level of fat. You can enable to liver to oxidation more fat within the liver, increase damage of cell, because firstly damage of nucleus, and then damage of hepatocyte, and then death of hepatocyte, either final can cause cirrhosis and hepatocellular carcinoma. So metabolic dysfunction of the liver is more crucial to management of metabolic syndrome or metabolic dysfunction of the liver. And as the focus of diagnostic stage, how to effect of metabolic dysfunction of diagnostic, because you can get of uncertainty result from the PET-CT, because in PET-CT depend on SUV. What is SUV is a measure of amount of uptake of FDG. If have dysfunction of the liver, metabolic dysfunction, so have hepatic steatosis, have inflamed area, you can uptake more FDG. use the liver as a reference in equation of calculating TBR, tumor background ratio. Physician uses radiomic feature of TBR to measure the response of chemotherapy and radiotherapy on the patient. So if TBR, if get TBR, more TBR in case non-alcoholic fatty liver disease come from these conditions, you can get uncertainty result, and maybe oncologists increase doses of chemotherapy because you can get a false negative from TBR. So if cancer patient have hepatic steatosis, should be management before start management of cancer by chemotherapy and radiotherapy.
Okay, we have another question here for you, doctor. Is any serological marker supporting the PET scan result in cancer patient or TBR values in fatty liver or non-fatty liver?
Okay, this is my recommendation for my research. You can consider the value of the liver is falls in case of fatty liver. You can use another organ like spleen or pancreas. You can depend on other organ as a reference in case calculating TBR without using the liver reference.
Thank you, doctor. And we have the last question, I think. Can AIs help in accuracy and the link of TBR values in fatty and non-fatty cancer patients?
TBR is many studies show TBR is more predictor, radiomic predictor for chemotherapy response. So it's important to calculate carefully TBR because the physician depend on these radiomic features. So in case fatty liver, okay, you can don't use the liver reference in equation of TBR to maybe use spleen, SUV of the spleen and pancreas is a major organ of the abdomen. In case non-fatty liver, you can use especially liver because is more suspected for uptake of SUV compared with another organ. But in case fatty liver, especially hepatic steatosis, you can use spleen or pancreas. These are my recommendations.
And I think here there's some part. Is there any research that's showing that we can use AI tools, artificial intelligence about this?
Till now, no, there is research about using the AI, artificial intelligence for this calculation because PET-CT need to radiologists have more experience about this normal area or no. If no experience for this normal area or no, you can get more false and negative result for patients. So the reporting for or interpretation of the result depend on the human till now because is need for more experience to on PET imaging because PET imaging more composed of function and structure. You can the function is a normal function of the kidney is a secretion of SUV. If radiologist or nuclear medicine specialist have no experience about this normal about increase uptake within the kidney because is a kidney secretion toxic. This is patients you can deal with radioisotope is toxic. So more secretion of the SUV by the kidney. So many issues of the PET-CT depend on experience of consultation of radiology or nuclear medicine oncologist.
Thank you very much, Dr. Magdy Ali, for your time and
Thank
for your explanation. We appreciate it.
Thank you.
Thank you very much.